application PowerPoints. Fine, how's that gone?
Yeah, I can see your screen. Have you put it into presentation mode?
I have. Is it gone? Is it just the overall screen, is it?
Yeah, so I'm just...
Let me have a look. Start sharing.
Yeah.
Let's try again. Share application PowerPoints. Okay.
Perfect, perfect.
Perfect. Got there in the end?
Okay, I'm gonna do my introduction and then I'll hand it over to you.
Perfect.
Okay. Okay, good evening, everybody. Assalamu alaikum. Thank you for joining us this evening for part 3 of this diabetes CPD series. It's with great pleasure we welcome 2 very renowned speakers, Dr. Phil Newland-Jones, all the way from the UK, and Dr. Ahmed Al-Alawa from Sidra Hospital. So before we start today, I'd like to bring your attention to our upcoming events. I'm just going to share my screen with you. So as I mentioned, this is part 3 of this series in diabetes care and management. These are weekly events, so they're appearing on every Tuesday. Our next event will be actually in 2 weeks' time, where we'll be looking at nutrition and lifestyle management in diabetes. And that's followed by diabetes self-management the week after. And then the final part of this series will be diabetes complications. So you can find details of all of the events we have running on our website. For those of you who are keen to join us sooner than that, we actually have an event tomorrow. So the next event will be medication waste, implications, challenges, and a direction for the future. And that will be tomorrow at 30 p.m. So we look forward to welcoming you to that event as well. For those of you who haven't been attending regularly, so we have a new process for claiming your CPD point. So following today's session at 8 p.m, you will see on the screen now, you'll see today's event. To claim your CPD certification, you can click on this link. It will become live at 8 p.m. today. This will take you to an evaluation survey that you'll be required to complete, and then we will issue your CPD certificate 7 days from today. There's no need to contact us. We keep a database of everybody who's attended and completed the survey, so we'll send that to you within after 7 days. I'd also like to take the opportunity to draw your attention to our newsletter. So this is a monthly publication that details our upcoming events and other activities we're involved in. We're keen as well to have our participants' views recorded in this newsletter as well. So if you'd like to share your experiences with us, we've created a new section that will share your experiences with our other participants. At this point as well, I'd like to welcome our viewers on YouTube. So welcome to our viewers on YouTube. Both on WebEx and on YouTube, we'll be monitoring the chat function throughout today's session. So you can type in your questions and any comments that you have, and I'll be sharing those with speakers at appropriate pauses within their presentation. So I think that's everything from me. We do, as always, we encourage your participation in our event. So if you do have questions throughout, then just type them in the chat, and like I said, I'll pass those on to our speakers. So for our first speaker today, we have Phil Newland-Jones from the UK. He's a consultant diabetes pharmacist, and he'll be introducing you to today's topic. So Phil, I'm now going to make you the presenter. You can begin to speak.
That's perfect. Right, let's get my slides up. Okie dokie. All right, can I get a nod from Zach that you can see it?
Yeah, that's fine. We can see that.
Perfect. Okay, so over the next couple of hours this evening for the CPD session, I'm going to be taking you through essentially the foundations of type 1 diabetes. I suspect actually I'll be saying some things that actually you didn't necessarily learn in any of our undergraduate courses, because actually our understanding of type 1 has changed quite a bit over the last 10, 15 years or so. And then the distinguished speaker after me is going to talk you through some of the more modern management of type 1 diabetes, utilizing some of the technologies that are available nowadays. So my name is Philip Newland-Jones. I'm a consultant pharmacist for diabetes and endocrinology and the clinical director of the Diabetes and Endocrine Service at Southampton. My office doesn't look like this. Behind the scenes are a number of nurses and registrars huddled about for MDTs. So yeah, I hope you like my new beautiful green office. Let's start off by essentially talking you through. We're going to go through the type 1 definition, pathophysiology and etiology, some symptoms and clinical findings, some landmark studies which it's often thrown about, and it explains why we treat type 1 diabetes the way that we do. A little bit about pharmacology and kind of understand the way that we manage it, some treatment goals, and then an overall summary just to round things up, which will set you in good stead for the second session of the evening. So what is type 1 diabetes? So generally, if we're looking at the overall spectrum of diabetes, there's a number of different types. There's type 1 alpha and beta, there's type 2, type 3C, you've got gestational diabetes, you've got secondary diabetes. So there's a list of classifications of diabetes that are well beyond just type 1 and type 2. But what characterizes type 1 specifically is, for 90% of them, is the immune mediation of it. So it's essentially your immune system has attacked the beta cells of the pancreas, which has led to a lifelong decrease in the amount of insulin produced yourself. Used to be called insulin-dependent diabetes, but nowadays many of our type 2s are technically dependent on insulin. So the ideas of NIDM and IDM are out the window. It's now very much type 1 and type 2. It's one of the most common chronic diseases. The peak is around 5 to 7 years old. More common slightly in male and female, and interesting enough, it sinks towards an environmental agent that initiates or drives it. So we tend to see bouts of patients coming in the spring and the autumn, and then we tend to see it quieter through the winter and the summer period. So there's something around an environmental trigger which kind of works on a genetic predisposition. So what we know is that essentially for almost 90% of the cases, there's an autoimmune marker, and Exeter in the UK has been the kind of the world base for developing more interesting kind of what genetic predispositions are there for type 1 diabetes from an autoimmune perspective. So we technically look for GAD antibodies, IA2 antibodies, and zinc receptor antibodies, and that will cover about 95% of patients with an autoimmune cause of type 1 diabetes. Generally speaking, it's the earlier you get it, the faster and more aggressive it is in terms of how fast it depletes your beta cells. And the later you get it, the slower the process. What's interesting as a fact is that most of your textbooks will say if you're under 18, you're more likely to have type 1, and over 18, that is changing dramatically. We've got plenty of type 2s being diagnosed at a younger age. I would also say that the median onset of type 1 diabetes is 30 years old. So there is as many over 30. In fact, I've definitely diagnosed more over 30s with type 1 diabetes in this last year than under 30. So it is not necessarily the way you think about it, that if they're young, it has to be type 1. Now, it follows a kind of a natural history where we end up with this genetic predisposition. We've got this kind of environmental factor which will drive a change. And over time, we've got this gradual loss in beta cells. Now that changes in how fast it can happen, but generally speaking, we only get to the point of there being a noticeable change in symptoms when you end up with a decrease in first phase response of insulin. So that's the kind of surge of insulin that your body, your beta cells will produce when you're requiring it for a meal. Then you end up to the point of having kind of a noticeable rise in glucose levels. And C-peptide is this marker that we look at, which is the C-terminal chain of an insulin molecule when it's released from the beta cell. So if that's present, then we know you're producing insulin yourself. That starts to decrease over time down to a point where the majority of patients will end up with no C-peptide and therefore showing that there is no endogenous insulin production. And it follows this pathway. Now, what's, I guess, fascinating about this environmental trigger is we've understood this a lot more nowadays in terms of if you have this kind of genetic predisposition, but actually the environmental trigger must be a local incident. So if you were to take a group of individuals or a genetically homogeneous group of individuals, say from a complete different area of the world, and you move them to another area of the world, so we take someone from East Asia and we take them to Northern Europe, they will actually begin to have the prevalence of type 1 diabetes of Northern Europe. So there is something in the environment of your locality which actually is what will trigger that process, which is absolutely fascinating. But generally speaking, the one main difference that we tend to see is that the older you get it, the longer what we call the honeymoon period is. So the longer the point at which you have maybe slightly raised glucose levels before you can become completely insulin deficient. And plenty of the trials nowadays are focusing on this kind of early pathway to try and stop patients kind of moving along down that pathway. So we've got tocilizumab, which was being used for COVID, but we've got temolizumab, which is another monoclonal antibody which has been used and shown to be positive in type 1 diabetes, that's slowing down the progression of it. So it is a fascinating area, but what it does show us is that although we label a lot of people as type 1 diabetic, it's more of a syndrome of a collection of different disorders in reality, because very few patients are the same within that, and I suspect they probably have different triggers as well. So what we also tend to see is a lot of the patients with type 1 are susceptible to other autoimmune diseases. So many will present with sometimes vitiligo, or sometimes a hepatitis, myasthenia gravis, thyroiditis, and Addison's disease. Also in the future, there's plenty of patients that will end up with Addison's and Graves' disease, as they are more prone to end up with autoimmune conditions. In terms of the symptoms of type 1 diabetes, we tend to see that typically, I guess it's under 40 years of age, but as I mentioned, the mean age is about 30 years old, usually lean or normal weight. What's noticeable is, I guess, the history in terms of the number of weeks of symptoms. So it tends to be a couple of weeks of symptoms where that's the case, but actually the older you get it could be 12 months, 13 months of symptoms, and there's plenty of patients that old and diagnosed with type 1 that end up, you look at the H1C and it's over 100 in our money, so that's over kind of 12-13% in the rest of the world's money in terms of the HbA1c, and that will technically show us that the blood sugars have been high for a long time in the background. We also tend to find then that they will end up not being needing insulin necessarily for a couple of years, and historically we've called those LADA or latent autoimmune diabetes. Generally speaking, the hyperglycemia is a random glucose of greater than 198 or 11 millimoles per litre, but the classic symptoms are kind of the 4 Ts, kind of, so polyuria, so peeing a lot, being thirsty, and this kind of classic weight loss. Generally, you just don't get weight loss with a type 2 diabetic patient that's diagnosed. The important thing is obviously as you get older, so certainly over 45, 50 years of age, any of these symptoms, we need to be ruling out pancreatic cancer in these patients as well to make sure that we've not missed anything. But weight loss, thirst, frequency of urination, often they'll be getting up multiple times per night to go to the toilet. General tiredness, they can get ketoacidosis, so kind of paired breath and faster breathing rates. Nausea, vomiting, so the nausea is indicative of ketoacidosis. Blurred vision and incidental findings as well. In terms of diagnosis then, so we've got the recommendations here. So these are the ADA classifications, which I guess is, I've not put in the nice ones because I think they're a little bit out of date at the moment, but generally speaking, we've got kind of that over 200 milligrams per deciliter, 11 millimoles as a random glucose, and the presence of 2 or more antibodies. So we tend to see a couple of those with eventually the point of a C-peptide being depleted and being less than 600. Landmark studies, so these are battered around a lot, but I think it's important to understand what they did. So the main kind of pivotal trial is something called DCCT, and it's a really large trial which looked at a big group of patients with type 1 across the US and Canada between the 80s and 90s. And essentially what they aim to do is to try and treat people with conventional treatment. So they gave 1 or 2 injections of insulin a day and just said we'll control the blood sugars reasonably, and that's what's called conventional treatment. Or they were intensively treated, either with an insulin pump in the early days or with multiple daily injections, and it was adjusted based on their glucose monitoring. So conventional or intensive. Those 2 groups are put through and randomized in terms of primary and secondary interventions for those. But actually what you can see across that time, so this is a 10-year period, is those that were treated intensively had a lower H1C, of course, as you might imagine, which led to a dramatic difference in the risk of complications. So originally, actually, although we've moved towards time and range, it was originally discussed as part of the DCCT. So it established H1C as the gold standard for assessing glycemic control because it can link to an average glucose. So we can look at an HbA1c, and there's plenty of studies now which will link that H1C across to a mean plasma glucose. So we know that an H1C of, say, 8% will be an average glucose of around about 11 millimoles per litre, or around about 200 milligrams per deciliter mark. Nowadays, we tend to use time in range a lot more, and a lot of clinical trials moving forward will use this idea of time in range just because we're able to monitor this a bit more frequently using continuous glucose monitoring, and our next speaker will talk in a bit more detail about this. Now, in terms of complications, what you can see is the main 2 that are the earliest to the microvascular, the small vessel disease complications of type 1 diabetes tend to be the smallest vessels first. So actually retinopathy is usually the first complication of type 1 diabetes that we tend to see from a small vessel disease perspective. So in a trial that's only 10 years long, it's a really useful marker to see what the risk of complications are going forward. So in DCCT, what you can see is, those with H1C that was, less than 10% or more, you can start to see the frequency of retinopathy goes up depending on the H1C. And the time in range is also linked towards that. So the higher glucose levels across that time, the higher your risk of developing retinopathy within that 10-year period. And it's quite dramatic. So you can see when it's kind of overlapped across with each other, we've got kidney disease on the left-hand side, nerve damage here, and eye disease here. So this kind of 70% risk reduction if you're intensively treated versus those that were given just 1 injection a day. So straight away, you can kind of say, well, actually, we really need to make sure these patients are being treated intensively. So it changed the way that we kind of looked at type 1 diabetes and said they need to be treated. What I always explain to patients is there's this lovely kind of exponential rise in complications. So the higher the complication, the H1C, as it goes along, obviously the more risk there is each time of developing those complications. So the difference between someone with an H1C across the bottom of 7 to 8%, or even 7 to 9%, is maybe a doubling in risk in terms of per 100 patient years. As soon as you start to get above kind of 9%, you can see that actually every 1% above that, it really starts to ramp up in terms of its risk of retinopathy progression. The same with microalbuminuria. Now, don't forget, it's a difficult one to look at because this is only 10 years, and it's one of the later complications of type 1 diabetes. So actually, I suspect if you repeated this trial for patients that were longer standing in terms of the diabetes, you might find that the graph looks a bit different in terms of the risk of developing microalbuminuria. It's a much higher risk when you start to get to an H1C of 12 over a longer period of time. Now, with type 1, the difficulty is we're balancing this risk of developing complications, and retinopathy is the easiest one to put up because it's the first one that's developed, with the risk of severe hyperglycemia. And obviously that is a trade-off between quality of life and risk of complications. So the difference is we're having to find a median, which is why we have this target range. But you can start to see, even with an H1C of 7 to 7.5% here, your risk of severe hyperglycemia is around about 60 episodes per 100 patient years. So it ends up per patient, it ends up with a couple of severe hypos per year as a result of driving their H1C tight with conventional therapy. So this was back in the day, obviously, when we used to have just a basal bolus, so 2 types of insulin being given. I'd say that these graphs are slightly different when we start to include some of the newer technologies that we utilize, which reduce the risk of hypoglycemia. So what was a really useful trial is at the end of this trial, DCCT, they then did something called the edict study, which is epidemiology of diabetes interventions and complications. And everyone who's in that trial was essentially then just followed up. So they essentially continued with a group of those patients, and they were carried on without any further intervention. So they were just monitored rather than actually had active treatment arms. And the patients in the control arm, in the kind of conventional treatment arm, were all advised to kind of move on to the intensive insulin therapy arm. And what you can see is fascinating is that, so here's the end of that kind of DCCT trial. You can see they're leagues apart. At year 10, the conventional treatment arm were told to tighten things up, bring their control back into the mix. And actually those that weren't being kind of followed up regularly then slightly lapsed in their H&C. So everyone ended up around about 8%. And they followed them up again at this point. But what's fascinating is that the benefits of good glucose control in the early years of your diabetes persists despite both of the groups being exactly the same. So in terms of cardiovascular events, so the macrovascular, large vessel disease, we got this 42% risk reduction by being on the intensive group to start with, despite everyone being around about the same for the years where they were monitoring for complications. So again, it shows us that early good control is incredibly important with type 1 diabetes, and that is often the problem, is that a lot of these patients are diagnosed when they're younger, and it's much harder. There's lots of things going on in your life when you're younger. And actually, unfortunately, a lot of the patients will transition into adulthood, and maybe they hit 25, 26 before they eventually get the control underway, but actually a lot of them have developed complications by that point. And this is one of the difficult things about type 1 diabetes in reality. So again, when you look at the same group in a 30-year follow-up, so the same group we then followed up many, many years since, you can eventually see that those that were treated intensively in that first 10 years had a decreased amount of cardiovascular disease 30 years later. And the time to your first occurrence of heart attack or stroke or anything like that, again, was a number of years delayed. So I think it was 3.5 years delayed by the fact that you'd been treated intensively to start with. So it really shows the idea about metabolic memory and the idea your body is kind of geared towards some of its complications through early glucose exposure. So complications. We'll quickly talk through the acute complications. So this is the one that everyone thinks of, obviously, with type 1 diabetes, is diabetic ketoacidosis, so DKA. So it's essentially caused by insulin deficiency. So this can be absolute or relative. And I mean, that's quite important to remember. It can be that, say, for example, a patient has just forgotten to take their insulin. They are absolutely insulin deficient, and therefore their body will not be able to utilize carbohydrate as an energy source, and they will end up developing ketones through free fatty acid breakdown. But it also can be relative. So if someone is unwell and their insulin requirements are higher because they've got insulin resistance because of a stress response, and they've not necessarily increased their insulin, and the blood sugars are running slightly higher, that is a relative insulin deficiency and can also lead to ketone generation and therefore onto diabetic ketoacidosis, which is why it's often linked with patients being unwell with another illness. So it instanced very dramatically on the population studies, the age of the person, the amount of education that's offered, and the support networks around that person. So the studies are very, very different when you look at the rates of DKA across the globe. But it's and actually, I do think when you look at the mortality in textbooks and in some of the actual studies, it's a lot higher than I tend to see. Like, I honestly cannot remember the last patient that unfortunately died of DKA, thankfully. It is luckily a rare occurrence if in a known diabetic. Unfortunately, we do have unfortunate circumstances where patients maybe haven't been diagnosed with type 1 diabetes, and it's a child being presented for the first time with a late presentation who may die of DKA. But generally speaking, our management of DKA nowadays has reduced the mortality enormously. And I think that obviously the global incidence rates are obviously linked, and the mortality is linked with populations with limited medical care. So in areas where there is, ready access to medical care to be able to get the right treatment, thankfully the mortality rates of DKA are a lot lower. It looks complicated, I promise it's not, but generally that just repeats about what I just said in terms of you've got this kind of absolute insulin deficiency or this relative insulin deficiency because you've got counter-regulatory hormones, so glucagon, cortisol, growth hormone, catecholamines. They will increase your insulin resistance. And because of that, you've got this disconnect between the amount of insulin you're giving and the amount of insulin that's required. And anytime there's a disconnect, you will then break down glycogen, you will increase proteolysis, you'll increase utilization of glucose, and you'll increase lipolysis to be able to get energy into the cells. You will end up with obviously increased ketones, and then your alkali reserve, your backup for trying to resolve the acid levels in your blood, will end up depleting, which will end up leading to ketoacidosis. And this is perpetuated by patients usually being peeing out glucose alongside this process. So you've got this separate process through lipolysis. You've also got a separate process through high blood sugars. And that means, your blood sugars are high, your body wants to pee it out. And as it pees it out, it drags water and electrolytes with it. And as it does that, you will dehydrate. And don't forget, anything that then dehydrates your body, glucose, salt, ketones, all of them are measured in a concentration. They are millimoles per liter or milligrams per deciliter. And for those, anything that decreases the overall liters will therefore concentrate those things and make it worse. So it's kind of a revolving process, unfortunately, in this. And the way to treat it is we give glucose and we give insulin. And that's simply the treatment for it. So the signs, tachypnea, so fast respirate or Kussmaul respiration. So they're very typical of being able to try and blow off acid levels to get rid of CO2. Respiratory distress, dehydration, so patients obviously look dehydrated, they're very dry-lipped, dry mouth. Fast heart rate because they're dehydrated, abdominal tenderness, and this can often be linked to kind of abdominal pain, and that's linked sometimes to the ketones that are present, and lethargy and cerebral edema, possible coma. So I had a patient in last week that presented as a new diagnosis of type 1 diabetes as a university student that had been isolated in his university halls. Thankfully, his mum had agreed to call him again 2 days later after he was feeling unwell on a FaceTime call. Couldn't get hold of him, sent the kind of security guard round who found him with a GCS of 4 in his university halls. But actually, it shows how things can go wrong if you don't kind of catch the early warning symptoms of peeing a lot and being very thirsty. But as I mentioned, it's thankfully treated much better nowadays, and we will just rehydrate the patient, give them insulin, and then give them glucose to make sure that you're driving carbohydrate metabolism. The other acute complication is low blood sugar, so hyperglycemia. So we've got different levels here, 1, 2, and 3, and these are kind of now recognized as the kind of 3 levels of hyperglycemia, and which ones we're kind of interested in the longer term. So level 1 is your kind of early warning symptoms, and you often sometimes don't even have symptoms of those. You've got level 2, which can be symptomatic but can self-treat, so you're able to kind of, your cognitive function is intact in those patients. That is not always the case, and some patients are definitely not and unable to self-manage. And level 3 is requiring kind of third-party assistance, so you require another person to support you, or you are in a coma or seizure. And it's often this happens when patients are either caught unaware, or they've lost the awareness of these other symptoms, the early warning symptoms, which can happen over the long term with diabetes. So the symptoms of hypos tend to be, I would say at this point, they're very specific to the person. So often in clinic, you'll ask someone, actually, I yawn, and that's my symptom. As soon as I start yawning regularly, I know that my blood sugars are low. So everyone have very slightly different things, tingly lips sometimes, but shakiness, irritability, confusion, slightly faster heart rate, and hunger. So the first description of hyperglycemia ever written in text was kind of essentially, I think, described as a feeling of unease followed by insatiable hunger. And that's it's really noticeable that they'll often have people that will self-correct their low blood sugars with an enormous rise in glucose afterwards. Now, incidence tends to stay slightly higher throughout. So this is events per patient years, and this is serious hypo events. And you can see that generally speaking, they stay high throughout, but actually what we see is severe hypos tend to increase in duration. So the duration of diabetes, as it goes up, we tend to see the severe hypos gradually increasing in the amount of episodes per patient years. But interesting enough, very few patients are actually free from hypos, which is why in clinics we're always asking that question as to what to say. And the reason for this response is in terms of the number of patients. When we start to think about why patients with type 1 diabetes have more severe hypos as they age, is that actually your response to low blood sugars diminishes. So if after 15 years of having type 1 diabetes, the amount of cortisol, the amount of adrenaline, and the amount of glucagon you produce as part of your counter-regulatory response is diminished enormously. So A, you're more likely to drop fast because you've got no counter-regulatory response, and the symptoms that come with adrenaline, that kind of anxiousness, the shakiness, the anxiety, they disappear. So those early warning symptoms eventually, unfortunately, type 1 will disappear. But in terms of the consequences, I think that you have to think about the person first of all. So psychosocial consequences, the glucose targets often end up going up, the patient's quality of life will change, and actually a lot of patients are fearful of low blood sugars, and they will purposely keep their blood sugars high to avoid hypos, despite prolonged effects of having complications of diabetes. But one thing I tend to see a lot of in hospital actually is cardiovascular events. So those that have had a heart attack or a stroke caused by a severe low blood sugar. And the reason this happens is that you release interleukins, you release clotting factors, you increase your platelet aggregation when you have a low blood sugar. And alongside that, you've got adrenaline, which is making your heart rhythm maybe slightly beat out of kilter. And you combine that kind of out of kilter beating with an increased risk of clotting, and you end up with an increased risk of CV events. And this is often missed. Everyone will think of coma, falling over and breaking a hip, or driving and causing a crash, but actually much more commonly I'll see someone coming with a severe hypo linked to a cardiovascular event. And then you've got social consequences. So people that lose their jobs, potentially they can lose their livelihoods. They can also lose their families, because some people can be quite aggressive when they've got low blood sugar, and that can destroy relationships. Unfortunately, they often get this kind of Jekyll and Hyde scenario where they're lovely, but actually when they've got low blood sugar, they can be quite aggressive towards partners. So social consequences should not be underestimated. But you often find that maybe people lose their driving license, they will avoid maybe social or sporting activities because of the risk of low blood sugar. And it's difficult. It is difficult. So I think it's a really multifactorial area that is hopefully a bit more understood nowadays. And Brian Fryer, just type his name into Google and you'll find everything you ever need to know about low blood sugar. The man is an absolute legend. So the fear of hypo, again, I guess it conflicts directly with this treatment success. So you can see that actually this is the percentage of patients decreasing their insulin dose following a hypo event. So about 3/4 of patients with type 1 diabetes, for both non-severe and severe, will decrease the amount of insulin they are taking. And interestingly enough, there's when you actually ask patients, I would treat patients more aggressively if there's no concern about hypos. I guess it is specialists and primary care physicians. Both of them would feel that they would kind of up titrate insulin a lot more readily if they weren't concerned about hypos. So, when we get to the stage of having an insulin that will automatically switch off in terms of its activity when the blood sugars are low, I think we'll find H1C getting a lot better. And we're not far off that sort of technology, thankfully. Risk factors for hypos. So previous episodes, a massive risk factor, and certainly a previous episode within the last 24 hours. So once you've had a low blood sugar, your body's response is to release glucagon. Once you've released that glucagon, you've not got loads more to release from the liver. Your glycogen will convert into glucose, and that's about it. So it means that if in the next 24 hours you have another low blood sugar, that response is diminished the second time round. So history of severe hypos, tight H1C control, glucose variability. So what we tend to see are actually those that have peaks and troughs in their glucose levels are much more likely to have hypos than those that run slightly low or slightly high, but more stable. Long duration diabetes, as I mentioned, kidney disease, so renal impairment, impaired awareness of low blood sugar, advanced age, therefore the ability to kind of time insulin with food, lack of food, and that often happens in hospital settings, that their insulin is not timed with the meals that are coming. Insulin itself, obviously an activity, and this is a big one. You could do easily do a whole lecture in itself just on how activity affects blood glucose levels in different ways and what sort of activities affect glucose in different ways. It is a completely area of diabetes management in itself. In terms of symptoms of low blood sugar, again, as I mentioned, that it decreases with age. So you can see this is the sweating and tremor. And as soon as you get past that kind of 15 year, as I mentioned, you'll see that the symptoms, so less than 50% of people after about 20 years of having diabetes of type 1 will end up having symptoms of sweating and tremor, the early kind of warning symptoms. And the more patients will have severe hypos without any warning. And this is the concern when it comes down to then, certainly in the UK, a single episode of severe hypo without warning means that you lose your driving license until you can prove that you've not got low blood sugars again. So it has a massive impact on patients' lives. What about the chronic complications? So I know you obviously got another session on this later on, so I'm not going to dwell in detail on it, but the main kind of three for microvascular, so small vessel disease, is retinopathy, nephropathy, and neuropathy. So retinopathy is really, really linked with duration of diabetes and glycemic control. The better way to term that is exposure to glucose over time. So the longer you've had it, obviously the lower it's going to need to be to reduce that exposure. And that's why, unfortunately, those that get diabetes at a younger age are at increased risk of getting retinopathy than those that may be diagnosed in their 40s, just because they've got a longer exposure and they therefore need to be extremely tight control to be able to reduce the risk of this disease process. Again, hemorrhages, and often it can lead to blindness, unfortunately, if you've got proliferative retinopathy in terms of hemorrhaging. Nephropathy, again, very different in terms of its risk factors. To be honest, often you'll find it's a two-stage process. So a lot of these patients will have macrovascular problems with the kidneys as well. But we tend to see it's a progression from microalbuminuria. So this is protein in the urine. And a certain percentage of those patients will progress eventually to kind of overt nephropathy, where they are losing a lot of protein per day. And we tend to find this is happening because of, again, increased glucose levels will drag water wherever they go. And so your kidney is trying to filter out those increased glucose levels, and it drags water with it. And as it drags water with it, it increases the pressure in the kidneys. And when you've got increased pressure in the kidneys, it starts to force out the proteins. A bit like, if you're draining rice and if you were to push that rice down and put some more pressure in it, you might force some of those grains of rice through the kind of drainage holes. And this is what happens in the kidneys. That pressure will push the proteins through, and it causes scarring and sclerosis of the kidney. And in doing so, you end up with that then leaking protein and causing renal failure. And then you've got neuropathy. So it leads to kind of thickening of the axons and eventual loss of the neurons. Eventually, we tend to see people with reduced sensation in the feet, and that in itself is not a problem until you realize that you stepped on something and you didn't realize for 2 days. On a Friday, I do a foot clinic regularly, and people will come in with drawing pins still in their foot without realizing they've stood on them. I had a patient that stood on a plug socket and had a really strange kind of 3 marks on a foot, and you're like, what did you do? Why have you got an ulcer there? She had, I have no idea. And I was like, well, that looks a lot like a plug to me. She had no idea she stepped on it. I also had a patient come in and had a little roll-on deodorant stuck in the bottom of their shoe. They didn't realize was there, and they just put their foot into the shoe. And that's the problem, is that it's not necessarily the neuropathy that's the problem to start with. It's the fact that then when you can't feel it, you might catch the side of a cabinet or a chair and end up damaging the foot, and that in the longer term then will lead to risk of ulceration, and then when you've got reduced blood flow, reduced healing, which can lead to then some of the problems with diabetes. The other problem is the pain. So the constant tingling and electrical pain. So neuropathy leading to neuropathic pain is one of the hardest things to treat in someone with diabetes, because the treatment is often not very effective, and some patients can lose, unable to sleep completely, because every time they put their feet up at night time, they get this excruciating kind of electrical tingling pain in their feet. So again, it's that's much more of a quality of life issue to the person. There's a macrovascular, so the larger vessel disease problem. So again, we know that type 1 increases the risk of having a heart attack, and we know that certainly any kind of cardiac disease is the leading cause of death in type 1 diabetes. So don't for a second think that type 1 is all about just the sugar. It's a macrovascular risk factor in itself. And actually, if you were to look at any of the prediction calculators that we use for when to treat a patient with a statin, you, interestingly enough, go from no form of diabetes, put the same risk factors in and put type 2 in, and then change that to type 1. And you'll see how much more risky having type 1 diabetes is for having a heart attack or a stroke is than type 2. And a lot of that is, again, I guess, about exposure to glucose over time. Is they're much more likely to have had a greater exposure to glucose. Peripheral arterial disease, as I mentioned, that linked with neuropathy is a really bad thing for patients, and you'll end up with an increased risk of amputations in that group. And then the risk of stroke again. So there's a risk of ischemic and hemorrhagic stroke, both with type 1 diabetes, and the outcomes are actually worse for those that have type 1 with exactly the same other risk factors. So in terms of deterioration and, unfortunately, death. So there's the main complications, but I don't think they should be, we should be aware of them, but thankfully all hopefully treated in clinics. So I guess overall, it's worth noting that substantial patient duration of diabetes, race and ethnicity also play factors. It's, I guess, not understood necessarily about why type 1 in specific has an increased risk of CV events compared to those that maybe have type 2 at a younger age. The same for mortality. So it's about every 1% increase in H1C beyond kind of this age range, 45 to 64, you find there's an increase of 50% of relative risk increase. So overall, we have to then combine this with other risk factors, and I unfortunately didn't underline this at the time, but smoking is an absolutely enormous one. So type 1s that smoke, it really doesn't go well for them in terms of cardiovascular risks. They will end up with a heart stroke a lot younger compared to those with, that don't smoke, unfortunately. So on to the medicines bit. So pharmacotherapy for type 1. So generally speaking, the evidence is really kind of robust in saying we should be using analogs, we should be using multiple daily injections or continuous infusions of insulin, which will be discussed in the next session. And again, most individuals should be using rapid insulin analogs to reduce hypo risk. So they've got a quick onset and a short offset, which means they're in the system and out the system nice and rapidly to try and time them with meals. And the reason for that is to try and reduce the risk of hypos just before your next meal. So the older insulins, the shorter actins, will kind of have a hangover effect of a number of hours. So once your carbohydrate has already been absorbed, that insulin is still acting and therefore is not as responsive as we need it to be. So analog insulins or continuous infusions on insulin pumps nowadays are the recommendations, and that's the same for NICE and the ADA and the International Diabetes Federation. In terms of the other two, which is what I've put in there just because it's out of interest, because actually, although it's not licensed, the top one, incretin-based therapies. So these are things like liraglutide, exenatide, dulaglutide, semaglutide. For those that do have, they're overweight with type 1 diabetes. I do tend to use it sometimes in clinics for those with type 1 diabetes, because you can still get the weight loss for the benefit of these medicines, so 3 to 6 kilograms, just like you would in a population of type 2 patients. So for those that are overweight, it's quite a useful therapy to use alongside. Off license, it's worth mentioning. But actually in that context, we do get some benefits to patients with minimal risks included. And then there's also SGLT2 inhibitors. So in the different countries of the world, there's different licensing for these, and also different experiences. So in most of Europe, dapagliflozin is one of the SGLT2 inhibitors that is used as an adjunct in patients with a higher BMI with type 1 diabetes. What is worth saying is that they essentially work by making you pee out glucose through the kidneys. And in doing so, you could still do that if you have type 1 diabetes. We tend to see the glucose levels tend to be less erratic, and it brings their glucose levels into a slightly tighter range, and their overall insulin dose tends to come down. However, if your BMI is above 27, it doubles your risk of diabetic ketoacidosis. And if your BMI is below 27, it quadruples your risk of diabetic ketoacidosis. So there is a trade-off for using them, despite their license. And I honestly don't tend to use them that much in my clinical practice nowadays. Even despite the benefits, I would actually consider other options first. So that is for interest rather than saying it is common practice. H1C targets then. So for the majority of people in non-pregnant adults, we're looking for an H1C of around about 53 or 7%. So for those selected individuals, especially those on continuous infusions, we can easily get a bit lower than that and actually target a bit better. Certainly for those on closed loop systems, I've seen people with even tighter targets than that and no hypoglycemia. And again, closed loop insulin systems will be discussed in the next session, as I understand. And then for those that maybe have severe hypos or limited life expectancy or extensive comorbidities, then actually releasing the targets, as I mentioned right at the start, the risk of your H1C going up from 7 to 8% didn't show that much difference in terms of your risk of developing complications. So actually, it's a completely reasonable target for most. And for the kind of prandial glucose, we've got the 80 to 130 milligrams per deciliter, kind of before your meals, and postprandial, we're looking kind of less than 180 for the rise. So this is if you're trying, especially for pump patients, trying to find the flexibility in that. What I want to show you now is that a little thing just to remind you about glucose testing. So here's The glucose numbers on across the left-hand side, hopefully some of them will be familiar to you. I'm going to put 3 patients up in front of you. So patient number 1, blood sugars are around here. And I want you to all in your minds just to think, are you happy with that? Yeah, it's pretty good. Quite happy with that. I'll put patient number 2 up. And depends on the circumstances, we can be unhappy or happy with that. But it's not horrendous, but it's certainly raised. And it will need gradually bringing down, but it's not necessarily erratic. And then patient number 3, erratic. So hypo, very high blood sugar, hypo, very high blood sugar. And in your mind, you're hopefully thinking, yes, it's in red. He's put it on the screen in red, therefore it is bad. Now, what if I was to say that this is the same patient? And it's important to remember that whenever you're looking at any data, including glucose testing data that patients will bring you, is that your mind will draw lines between the 2 data points. That is not necessarily true. And gaps in data, anything could be happening. So it's really important to get a thorough reading of glucose levels when you're going to be making suggestions to patients' treatments. And this is the reason why we've now moved more patients into using continuous glucose monitoring, because it gives you all of these gaps in the data. It gives you the data for them, which is much easier to kind of give you a fuller picture and make a more robust choice in treatment changes. In terms of factors that affect insulin treatment, then obviously technique makes a massive difference. Unfortunately, I didn't put a slide in, but I regularly find patients with enormous lumps of fat in their injection sites, which reduce insulin absorption. This is called hyperdystrophy. And a lot of those patients will end up with really high insulin doses. It's quite easy, we should be checking injection sites at every clinic appointment, but actually, if anyone works in any other setting, you can kind of be hinted towards these things. If you've got a type 1 patient that's on certainly more than 1 unit per kilogram for their weight, a 50-kilogram person on 80 units of insulin a day, that is often not going to be correct. And so you want to be definitely checking for where they inject their insulin in those patients, because it's often you'll find big lumps under the skin where they're injecting it. Meal timing, exercise, stress, weight loss over time, and intercurrent illness, all of these can massively affect the dose of insulin that you need to take, which is why patients need to be flexible and adjust it day on. And then in terms of other things, I could do many slides on this, and you could probably again give sessions in itself on these, but psychological factors, so people that avoid maybe giving food and avoid giving insulin because of weight issues, and I have a couple of those in clinic. Those that are overweight, age changes your fat distribution in the body, and therefore how you handle glucose. Your muscle mass is decreased, and therefore again how you handle glucose is changed over time. Kidney and liver function, so how fast you clear insulin from the system as well. Blood flow, temperature, so hot temperatures versus cold temperatures. I've regularly have people that go on holiday and their absorption of insulin is so much better when the blood flow is increased and your skin temperature is increased. Again, the actual insulin itself, so the concentration of the insulin, the albumin binding of the insulin, the solubility. We've obviously got concentrated insulins nowadays, which can be used. We've also got rapid acting insulins, so those that may be paired with different vitamins, which will help absorption into the bloodstream. And also depth of injection. So anything beyond 8mm needle is almost 50% deposited in the muscle rather than in the subcut tissue. So smaller needle sizes are perfect. We never really should be given bigger needles nowadays. Dose distribution, again, for those on a larger dose of insulin, maybe given it over 2 injections rather than 1, if acceptable to the patient, will really help with the distribution of that insulin in the body. And certainly a lot of the time, adherence. I'd be interested to find, we've now got the onset of kind of Bluetooth pens, insulin pens. And I think it'd be really interesting to be able to see then the timing of insulin with meals, actually, because you have all the data on the screen in front of you. So treatment goals, what are we aiming for? I guess to be as close as possible to the body's own normal insulin profile, which is to have rises in line with when you have carbohydrate rises in the bloodstream, but also rises to be able to switch off glucose production in the liver when you're about to eat a meal. So the reason we're trying to give insulin just before the meal is so it gets into the bloodstream, it's able to get to the liver and switch off your glucose production in the liver. Because what you don't want to happen is for your carbohydrate to be absorbed, and that is added to the glucose that your liver is producing, because that's generally why patients end up with high blood sugars after a meal. It's not just what they've eaten, it's the fact that their glucose levels their glucose production hasn't been switched off in the liver. And obviously, the traditional approach in type 1 is rapid analog each meal and then once or twice a daily insulin. Generally speaking, 0.4 to 1 units per kilogram per day patients end up having, but I would say during puberty, I've seen much bigger doses, especially in females going through puberty, interesting enough. But typical is about 0.5 units per kilogram, I would say, and generally as an overarching rule, around 50-50 if we're trying to divide it up. Put a couple of slides together, and if there's any dietitians in the audience, I apologize for dumbing this down, but I'm going to give you 4 slides on carbohydrate counting just so you can understand and appreciate what type patients type 1s do at meal times. But essentially, step 1 is we teach the patients where the carbohydrate is in their diet. You know, it's in the breads, the wheats, the grains, the potatoes, the pasta. Some of the other sorts of food as well, a little bit in dairy, and there are some in vegetables, but it's very much bound to fiber, so we tend not to count them as much. We then, if you've got a package, you could easily look at the actual amount of carbohydrate per 100 grams, divide that by 100 and times it by the weight. So, you know, certainly if we're doing pasta and we're teaching patients to understand how many grams of carb are in their portions of pasta that they eat, then this is by far the easiest way to do it to start with, and they will learn, because people don't tend to necessarily change their portion sizes. They will just cook the same amount in the pan that they always do. Eating out is often a little bit more difficult because obviously you have less control over the portion sizes and you have less control over what goes into the food. You could also use something called Carbs and Cals. So a lot of these patients are either given a booklet or there's an app online which is really useful, and it'll give you approximate amounts of carbohydrate for different plates of different foods, and it's a really useful app for patients to be able to find their way through carbohydrate in their diets. And then what we tend to do is we give an amount of insulin for the amount of carbohydrate the patient is going to eat. So the patient might have, for example, 1 unit of rapid insulin for how many grams of carbohydrate, like 1 for 10. As a rule of thumb, it could be based on weight to start with. You could be based on the amount of long-acting insulin to start with, or we could essentially take the total daily insulin dose and divide it by 400. So someone is started on a general dose of that, you know, maybe 0.3 to 0.5 units per kilogram. We'll find that out, and then we'll divide 400 by that. So it used to be called the 500 rule. Generally in our service, we'd use 400 rule. And that will give you an amount of carbohydrate for an amount of insulin. So you'll give 2 units of insulin for 20 grams of carbohydrate, or 3 units of insulin for 30 grams of carbohydrate. Then the second thing we do is we add a correction dose on top. So we give more insulin if their blood sugars are kind of above target before the meal. And that's because we're only matching beforehand with the amount of carbohydrate you're going to eat. That doesn't necessarily correct you back down to a normal number. So, and that will either be generally, as a rule of thumb, you could do it on weight to start with and then adjust it accordingly. Or again, you could use a total daily insulin dose. So around, again, it used to be called the 100 rule, but actually 130 tends to work a bit better. So 130 divided by your total daily insulin dose. And that will give you how much your glucose levels will drop by. Actually, it's worth noting at this point, I've put this on, but it's the millimoles per litre. So the rule would be different if you do it in milligrams per deciliter, but the principles are the same. So you would end up with 1 unit of insulin drops by a certain number of milligrams per deciliter. So as an example to put it into practice, I've got a patient with a carb ratio of 1 unit to 10 grams. They've got a correction ratio of 1 unit drops their blood sugars by 3 millimoles here. So that's around about just under, 60 odd. Glucose level is 18 millimoles per litre currently, and they're about to eat 50 grams of carbohydrate. So we know that they need 5 grams for the carbohydrate in their meal. And we know that they need to go and drop at least 18, 17, 16, 15, 14, 13, 12, 11, 10, 9. So we're looking at maybe 8 to 9 units of insulin for that meal to match what they're about to eat and to correct what their blood sugar was beforehand. So sounds simple, but you try doing that 3 times a day, and then you try doing it when you've got fat in the meal, which affects how fast the carbohydrate's absorbed, and protein, which affects it. And it ends up being really complicated, and actually you need reasonable math skills to do it. And that's sometimes the downside, is that the general level of maths is not always great in a lot of populations. So you need a reasonable level of math skills to be able to do carbohydrate counting if you have type 1 diabetes. But there are technologies available to help. So we got kind of calculators that are available as part of glucose meters nowadays that will help in that process. So overall summary, chronic disease, lifelong administration of insulin can happen at any age. And it's worth noting we use monoclonal antibodies like pembrolizumab in patients with cancer that will induce type 1 diabetes. And I've had 93-year-olds having type 1 diabetes induced by monoclonal antibodies. So it includes polydipsia, polyphagia, so weight loss, drinking a lot, eating a lot, weeing a lot, and tiredness. And obviously that's linked to the symptoms of high blood sugar. DK is one of and hypos are the main complications acutely. And then chronic complications, we've got small vessel and large vessel disease, which we've discussed. And then hopefully what we'll discuss in a second is a little bit more around the continuous infusions. So patients should have basal bolus where possible. These are the principles of the trials, but technology is becoming a much more important role in the management of type 1 diabetes. And certainly it's changed dramatically over the last 10 years in terms of patients with insulin pumps and integrated sensor augmented systems and continuation of continuous infusion. So that is going to be the beautiful next session you're going to have from the next speaker. So thank you very much for listening, and happy to take any questions at this stage.
Thank you very much, Phil. Very informative presentation. There isn't enough time to ask all of the questions. I'm just going to select a few that have been put to us. So in younger patients, you mentioned that the earlier patients can get their blood sugars under control, then the better outcomes there are. So what approaches do you recommend for your younger patients to encourage that sort of getting their blood sugars under control?
So I tend to only see transition patients, but actually, so they're a little bit older. But I know that obviously we have a pediatrician coming up next, so he may can answer and start his session with what he would do. But actually, generally speaking, all of our type 1 services have a psychologist attached to them. They are integrated in the service, and that is absolutely key because it makes such a difference to that young person's life. So psychological support early on in the disease process, I would say, is absolutely essential. And it's in the UK, it's classified as one of the absolute requirements, is they need 18 contacts per year, and that can be through face-to-face, telephone, other bits and pieces, but they will have to have at least a touch point with a psychologist once a year, and often it's more than that. But there are patients that really do need that support. So I would say that's essential, and a strong family unit with a supportive family, again, makes a massive difference.
Thank you. So it looks like a question from one of our nurses. You mentioned about the technique for administering insulin and the problem that the fatty tissue deposits can create. So what's the specific advice that you give to your patients around administration of insulin?
Yeah, so regular rotation of your injection sites and making sure you're not reusing needles. So single-use needles where possible, or not using them too much. So the more times you use a needle, the more likely you are to end up with lipohypertrophy. Rotation of injection sites across the whole abdomen into the upper arms is also fine. Top of the buttocks if necessary, and also into legs if you've got enough fat there. So rotation of injection sites, using small needles and changing your needles as well. So those are the kind of three top tips to try and reduce lipohypertrophy. If you do find a patient that's got it, they will often need a dramatic change in dose, a reduction in dose when you move injection site. And if you don't do that, they can end up with very severe hypos. So I had one who came in at the start of winter with just after their flu vaccine with a severe hypo, and it's because their GP nurse had noticed that they had a big lump where they'd been injected into, where they're going to have their vaccine, and they told them to move the site without changing the injection dose, and they had their first dose after changing site and ended up with a catastrophic hypo requiring an ambulance to bring them to hospital. So when you do find it, they will often need a very big dose reduction when you move to a normal site.
Thank you. And final question before we move on. So you mentioned that one of the risk factors for recurrent hypos is actually having a hypo. So how should these be managed in order to prevent the reoccurrence?
Yeah, so it's making the patient aware. So as soon as they've had a low blood sugar, the fact that they know they're getting more at risk for the next 24 hours is a useful thing for them to know about, because not all patients do know that. Making sure that you're following up your immediate treatment of the hypo with some complex carbohydrate. And actually what we tend to say is for the rest of that day, patients should make sure they're having carbohydrate at each mealtime, and that's to make sure they can replenish the glycogen stores. So being aware that they need to go to bed with a blood sugar that maybe is slightly higher than usual, and they will need to make sure they're having carbohydrate with their next couple of meals so they can replenish their glycogen stores in the liver.
Brilliant. Thank you very much, Phil. If there are any questions, if it's okay, I will put them in a document and email them to you. And if you, when you have time, just respond to them, and then I can pass on to the friends today.
Yeah, can't wait.
Thank you very much. So our next speaker, Dr. Ahmed, I will now make you the presenter so you can share your slides with the participants.
Yes. Is it showing now?
Yes, we can see your slides now. Thank you, Doctor.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Zakaria, for the invitation, and thank you, Dr. Philip, for the making my presentation easier with your marvelous presentation and introduction. Today, I'm going to speak about the role of technology in type 1 diabetes, and technology. Here is my disclosure. And I hope by end of this session that we can understand and be able to describe and explain the insulin delivery options, discuss what's an insulin pump and continuous subcutaneous insulin infusion, and the role of tight control and the concept of continuous glucose monitoring in management of diabetes. Just a quick review what Dr. Philip mentioned about how we are replacing insulin in type 1 diabetes. It's an insulin secretion profile in the pancreas. It should be a background insulin all through, which is a basal insulin, and a bolus insulin, which covers the carb content of the meal. Or in the diabetic patients, the bolus aims at correction of what has been high blood sugar needs to be back to target. So in insulin regimen, we have here are many basal insulin, like the insulin glargine or degludec or detemir. These are peakless insulin, and the old use NBH, it's intermediate acting insulin, which is not good basal insulin, still used because of the financial. It's cheaper than the other basal insulin, while it's not good for children. And now everyone shift to the peakless analogs basal insulin. And the bolus insulin includes many available insulins in the market. And now we are using the ultra short bolus insulin. So the insulin delivery methods starts from the very basic classic way of insulin delivery, which is the insulin syringe, and moving through the insulin pens, which is widely used, and no more we are using syringe in most of the countries, and passing through, and then going to the insulin delivery through the insulin pump, the continuous subcutaneous insulin infusion through the insulin pump, whether it's integrated with the continuous glucose monitoring or it's not integrated with insulin with the continuous glucose monitoring. So just a quick comparison between what's insulin pump and what's multiple daily injection. The insulin multiple daily injection, as we know from the previous session, that it needs long-acting insulin. It's one injection most of the time, and bolus insulin to be given with meals to cover carbohydrate. So the basal insulin is there. It's one injection and the bolus for the meals. While in the insulin pump, we use only rapid-acting insulin. Like the physiologic insulin, we don't have in our bodies basal as long-acting and short-acting. It's all rapid-acting insulin continuously pumped as a background, which stands for the basal, and it will be burst upon carb intake, so it will be the bolus. So for the multiple daily injection, you need to give a bolus for every meal, And sometimes if you are eating too much, so you need to take many boluses for the 3 meals and for the snacks by injection. For the pump, you give the same, but there is no injection, it's needle-free. The basal insulin, once injected for the multiple daily injection, you cannot change the dose of the basal insulin all through the 24 hours. But for the pump, it's continuous pumping short-acting insulin as a background. So you might interrupt this pump, or you might change the basal rate during every hour or even every half an hour, but we don't use it that frequent, but you have the option to change the delivery rate of the basal. And for the MDI, there is no attached device. You only use the pens whenever you are injecting, while for the pump, you need to have an attached device and cannot be disconnected. Why all of these efforts to improve the insulin delivery technique or improve the insulin dosing? All this based on the gold standard study 1993, which is a DCCT trial, which stated that the better the control or the mild type control with at that time was the hemoglobin A1C is the key performance indicator, and the lower the hemoglobin C, the less the complications, and the complications was dropped up to 80% or near 80%, and this was the motivation or the trigger for better control. The trials to have insulin pumps started very since a very old time, and it was like this to start the trial of having a pump and ending up with this very smart, small-sized, good-looking devices used as a pump currently. So it's very important to explain to the patient everything about the pump, what is insulin pump, what is the expectation of insulin pump, how you are going to operate this insulin pump, and the patient engagement is very important, and the better understanding before start will give a better expectation and better motivation. So just to know about the insulin pump, it's external programmable device, continuously deliver insulin via indwelling thin subcutaneous catheter by a tube or without a tube. Now some pumps are tubeless pump, and most of the pump in the market are with tube. It requires still input data for the bolus, so you need to enter how much carbohydrate the patient is consuming. For the calculation, the pump has a setting of how to calculate for the insulin carbohydrate ratio and the insulin sensitivity factor or the correction factor. So the patient needs to give data still to the pump. It's operated by AAA battery, most of them, and holds from 200 to 300 units of rapid-acting insulin. Most of the pump stays for 3 days. So if the patient is consuming from 70 to 100 units per day, it will be suitable to have the pump for 3 days. As we said, there is no long-acting insulin anymore used. So you use only rapid-acting insulin, and the insulin delivery in 2 ways. Basal insulin, and it's calculated against how much units is delivered per hour, and the bolus, and this stands for the carb coverage and correction. So the subcutaneous is the indwelling catheter. It delivers insulin subcutaneously, continuous infusion, so it's not a bolusing or a lump of insulin will not accumulate here. It's continuously infusing, and this cannula change in average 3 days. Sometimes in infants, we might need to change it every 2 days. This is a way of insertion. The inserter might use a needle, but the needle will not stay in the body of the child. So we remove the needle after application, and here is attached to the tube. And some other pump called patch pump, there is no tube at all. It's only stick to the body, and then you initiate the pump from the controller, remote control, and the delivery of insulin will start, and there is no tube, and both are available in market. So for the tubeless, it's as we said, it's a patch without tube. Here are the insertion sites, as Dr. Fair mentioned about the lipohypertrophy. Even with the pump, if you are not rotating the insertion, you might have lipohypertrophy, and this will affect the delivery of insulin. So you need to rotate first to know the insertion sites, and you know it's the lateral aspects of the arms, the thighs, the upper quartile of the buttocks, and around the abdomen. If you are using like this area around the abdomen, you can use whatever method to rotate this each time you rotate as if from 12-1 to, so every insertion will last for 3 days, so very unlikely to go back to the same side after 1 month and lead to lipohypertrophy, or you use this way of rotation. Don't forget that any device or any technology might have some interruptions or blackouts or device troubleshooting. So you need to know how to move to the manual way back to the pens or even syringe, and you have to have a backup, and you have to know your doses. It's very important to update every time or every visit with the doctor, with the physician, to update your doses from the basal insulin and the bolus insulin, because with time, sometimes you are not updated, and you can recall only very old doses before insertion of the pump. So you need to be updated every time. As indications, many people think that the pump is not only indicated for adults or for grown-up children. This is wrong conception. A pump is indicated from 0 day. You can insert pump in the neonate, and actually there is no all people eligible to insert a pump. There are no indications for the pump. There are contraindications to the pump. Many, if you go even to desire to improve life flexibility or to have a more convenient way of insulin delivery, or to have accurate delivery, or to overcome poor control, or to have better hemoglobin A1C. So most of this will apply for everyone, to decrease hyperglycemia, to decrease hypoglycemia. So everyone is eligible. And but you need to have a reasonable expectation, and if you have a high expectation and you think that the pump will cure diabetes, or the pump will take care of everything without any input from the child or the parents, so it will lead to a very poor outcome. So you need to be realistic about expectation, and you need to operate the pump properly. So some people think that the pump will take everything, take care of everything. It will cure diabetes. No need for any interest to the pump. The pump will integrate with the sensor even to do everything, and no role for the patient. No, the pump needs awareness, needs integration, needs inputs from for the bolus, and need attention not to be interrupted. The delivery of insulin, and this if the patient is not attentive, this interruption might lead to high blood sugar and even ketosis. So the pump has a lot of advantages: increased flexibility of lifestyle, predictable insulin delivery to the accuracy of 0.025, not 0.25, 0.025 units, precise insulin delivery, deliver very small doses, tighter control. You can achieve tighter control with less risk of hypoglycemia. Of course, it will reduce the variability and fluctuation of blood sugar. And all the risks are related to better education. Very uncommon and very unlikely to find the skin infection at the insertion, sometimes some allergy, and overcome by some applications or topical application of creams. But the risk of DKA means interruption of the pump or occlusion. So this means poor education and non-adherence to the troubleshooting. If the blood sugar is high, they should be attentive, and they can change the pump infusion. The cost of the pump is considered as disadvantage, but the cost of the poor control and complication is much high. And currently, pumps are of cost effectiveness, and even some pumps are cheap, getting cheaper with the wide use of the pump. Checking blood glucose with a continuous glucose monitoring now is easier, and integration even for the blood glucose with the pump is getting better. Letting other know that you have diabetes. Yes, if you have any patch like continuous glucose monitoring or a pump, may allow others to know, but most of the pumps are covered under clauses, and you still may not disclose to everyone about the disease if you are not happy to disclose it. The weight gain, actually, it's not a side effects. Weight gain means you cover all the food you are taking by insulin, and this is a good sign, not a bad sign. And you can control the carb intake within the acceptance for everyone, even with the use of the pump. So we actually made some scoring system for the readiness of the pump, just like to people are motivated, technology oriented, can do carb counting, and they are attending to the clinics. And we made this scoring will lead to, if the score is poor, so it's not eligible for the pump. If the score is average, this means some education can apply and still can be eligible for the pump. And if the score is good, so you can go for the pump. As we said, there are contraindications to the pump rather than everyone is indicated to insert a pump. But if someone is not happy with attached device, not using continuous glucose monitoring, not having blood sugar tested, cannot learn or practice carb counting, not documenting anything, not adherent to the medical therapy, not attending clinic, refuses attached device, all of this will lead to poor adherence, and the pump option will fail as well. So the pump will not work alone. So it's very important to have realistic expectation, comfortable with technology, committed, understanding the insulin injection level of activity and carb counting. You have a healthcare team aware with the use of technology, and you should be ready for attaching a device like this lady, Miss USA 2014. She attached the pump all through the competition, and some pumps are very small like this. It can be covered easily, and still you cannot see it. So everyone, after evaluation and explanation, understanding, at this point, you can insert the pump and be committed with the pump. So to go for some information about how to deliver the insulin, or how to calculate or use the pump, as we know, the basal insulin stands for average 40% of the pump as a total daily dose, and the bolus insulin stands for about 60% of the total daily dose. As we said, for the pump, I can change the insulin delivery for the basal and over the time, while with the MDI, if you injected whatever units of basal insulin, it will last at a steady state all over the 24 hours. And for the bolus, as we said, it's two parts, meal bolus, and it stands for the carb content of the meal, and correction bolus. This will bring the blood sugar back to target if event of high blood sugar occurred. And the best to give the bolus 15 to 30 minutes before meals in adolescents. If in small children, you might not be sure that they are going to consume how much carbs, or you might be sure that if you give early bolus, they might skip the meal or resist to have the meal. So with small kids, you might not go for this bolus, pre-bolus, what we call pre-bolus, and you give the bolus immediately before the meal. We have some, for the pump, we have some advanced options, the advanced basal option. So you can temporarily change the basal rate for a couple of hours. So from 30 minutes up to 24 hours, you can change the percentage of the basal, like reducing it during like exercise or so, or increasing it like during sick days or some menstrual days. So you can change the temporary for short duration, the percentage of basal rate, and this automatically will return to standard basal rate after the duration ends. As well, there are some other options that you can switch for patterns. So the basal rate, you can tailor a basal rate suitable for some pattern days like weekends versus weekdays, menstrual periods, days out, travel, or camping. So this pattern you can switch, but you need to tailor it against the activity or expected illness or so during these periods, and you need to switch from the pattern back to the standard manually. It will not end automatically after some time. We have as well advanced bolus features that you can give the bolus immediately, like any bolus you are giving by the syringe, but you might choose to extend the bolus over certain time if slow absorption of food is expected, or if you are eating small portions over 1 hour, 2 hours, so you might choose to extend, or you might combine what we call dual or combination. Part will be absorbed immediately and part will be absorbed slowly, and this combination in many of the fatty meal, and the famous example is using it during pizza. So why you are splitting it? Because the fat will make a slow absorption of the glucose. So if you are giving a small simple bolus or rapid bolus, so the insulin will be absorbed, leading to hypoglycemia here. And then when glucose is absorbed, the hyperglycemia will happen without any insulin. But if you tailor to part of the insulin to be absorbed here and the rest to be absorbed slowly, this will make matching between insulin and carbs. As Dr. Philip mentioned about the carb counting, we aim at the carb content of the meal. We don't aim at the protein content or the fat content. And this actually will lead some patients to say, it's okay, I will go for the keto option, like a carb-free diet, and I will omit all the 3 injections or for the bolus. We cannot encourage that actually, because most of the children are growing and it's a lifelong issue, problem, so it cannot be adopted for very long time. Keto to reduce weight for 1 month or 2 months can be tolerable, but for diabetes, we discourage this attitude. Carbs stands for 40 to 55% of the calories per day. And if you go below 100 grams per day, you might lead to mood changes and some unpleasant changes, and the growth as well will be affected. You need to replace these carbs. If you replace these calories to be protein or fat, which making the protein load and the fat percentage is not acceptable. So we discourage that. But as well, if the patient wanted to skip carb in 1 meal or couple of meals, it's not no problem. It's okay. He can skip and he can reduce the carbs below 40%. Still, it's a low carb diet, but still it's not no carb diet. It's low. He can go for low carb diet, but the recommended shouldn't be less than 40% of the total calories per day. So you need to count for the carb by measuring the weight or the amount of fluid if the carbs is liquid, or reading the labels of the carbs. As we said, why we are doing carb counting? Because if you go by piece, so it's this 1 piece of banana and this 1 piece of banana, and of course both of them, the carb here is much more than here, and still the same for the apple. So you need to have some measurement or weight and multiply by factor, and these beautifully designed tables designed by our dietitian, and this amount of carbs will be the size of the apple multiplied by grams multiplied by factor will lead to the grams of the carbs, so you know how much carbs in this amount of food. And reading labels as well. And when you read the label, you aim at the carbs, not at the calories. And as Dr. Phil mentioned, it is very important to read against the serving size and multiply against the amount you are gonna to consume. After setting up the setting of basal and bolus, insulin carbohydrate ratio, insulin sensitivity factor, and many calculations are used to do that, then you do the fine tuning and you adjust the readings to adjust the doses to have the readings you are aiming at. It's very important for the pump to change the infusion set every 3 days in average, sometimes less, sometimes more, sometimes 3.5 days, something like that. But most of the studies said after the 3rd day, there is a risk to have partial occlusions and increase consumption of insulin by 33%. So it's very important not to keep after, because sometimes due to poor compliance, here is a download empty, there is no BG reading, no food entries, not changing the infusion for up to 9 days. Fortunately, she didn't. She didn't have frequent DKA, but presented at the end by DKA. So it's very important. Even with technology, the compliance might lead to that you need to remove this technology and go back to pens. Still, she might not or he might not use the pen properly. So compliance has no end to affect the control. During sick days as well, it's very important to be attentive to the changes might happen and the entries you need to put to the pump. It's like here, this girl is not responding to the high blood sugar all through 1 day or the 2nd day. So at the end, it ended out by developing DKA. So it's very important to respond to the instructions or the readings, and you have to have as well a backup set to overcome any pump problems or occlusions. During exercise, actually, the pump will give you options, as we said, to tailor the doses against the expected effort you are going to have. And this, it can be, you can change according to some tables related to the intensity of exercise, and you have 3 options. You have option to decrease the basal, you have option to decrease the bolus, you have option to add carbs, the child can consume more carbs without coverage to overcome, to prevent hypoglycemia and tailor the amount of dose against the expected degree or effort to do. So temporary basal reduction, you can decrease the basal reduction like 80% even or whatever. So you can even during some exercise like swimming, you can disconnect the pump and remove the pump up to 2 hours. And by the way, many of the current pumps are waterproof. If you wanted to use the pump during the exercise at a very low basal rate, still can be, because most of the new pumps are waterproof. Hypoglycemia, it's very important to review what might be a cause of this hypoglycemia, like the dose needs to be adjusted or wrong entry, like he consumed less carbohydrates and he enters like 50 grams while he consumed 20 grams only. This will lead to more insulin delivery and or wrong data, means he consumes 50 gram or but he put 80. So he did the proper calculation, but he wrote the input in the pump was wrong entry. This will lead to hypoglycemia. Unplanned exercise or gastroenteritis might lead to hypoglycemia, or changing the daily activity, as we said, that during weekends versus weekdays, camping or exercising, this needs to be addressed and change the doses so to prevent hypoglycemia. Actually, hypoglycemia is very well preventable by using the technology, because you can go for temporary basal, you can go for patterns, you can, with the integration of the pump with the glucose sensors, as I'm going to mention in the second half, this will prevent and give alarms to prevent hypoglycemia. And this will lead us to the interaction between the continuous glucose monitoring and the pump. So started by pumps that suspends on low. So the sensor will give information to the pump that the blood sugar reaches the level in the setting considered as low. So the pump will suspend delivery for the basal insulin and suspend any even running bolus still not delivered or extended delivery. And the next generation, the suspend before low, and this applies for some models of the pump, and means that the pump, as a sensor, will make estimation for expected to reach the low after 30 minutes. So the pump will have this information and will suspend before reaching the low. And nowadays, we have what we call HCL, or hybrid closed loop pumps. This means the sensor will give data to the pump, and the pump will get this data to change the rate of insulin delivery. And this applies for the basal, these with some models, and recently in market it change it to the basal rate and give micro corrections for the bolus as well to overcome highs. So the hybrid closed loop currently, almost more than 80% of the doses are handled by the pump, and still I'm saying 80% because 20% because the pump still need data about the amount of carbs is going to consumed. So it's not completely closing the loop between the sensor and pump. Still there is a human factor of entries of the carb intake. That's why this is a hybrid closed loop, as we said, either basal only or basal and bolus. Sometimes some people say, okay, I wanted to remove the pump. Why? It might be because of lack of supplies, pump is broken, pump is lost or stolen, or if this child will go to hospital for surgery or for the diagnostic test, and needs to be admitted to the hospital, and the pump is not, the healthcare provider at this hospital is not aware how to deal with the pump, or pump break. Just please remove any attached device from my body for a couple of days or weeks or whatever. So it can happen, and we can tailor the doses back to the MDI and remove the pump and go back to the MDI, and after changing wanted to resume the pump, so you are going to resume the pump. You can have pump break without any change in the doses or anything for 2 hours. After 2 hours, you need to decide that you need to cover for this pump break by injections. Okay, in our second half of the session, I'm going to speak about the other monitoring of blood glucose, which is a continuous glucose monitoring. So the pump as a therapeutic model for technology use in type 1 diabetes, and continuous glucose monitoring is a diagnostic model for monitoring blood glucose, and the integration between both, as I mentioned, the hybrid closed loop systems. So the start of the need for glucose monitoring, continuous glucose monitoring, started by having these discrete readings, which is very beautifully between in target. And when you go for continuous monitoring, you might find whatever in between these readings, either high or low. So it's very important to have blood glucose checked in many occasions, like before meals, before snacks, after meal 2 or 3 hours to check how much blood sugar after meal. During exercise, not to have hypoglycemia. Before bedtime, to be sure that there is no hypoglycemia at bedtime. During the night, to check for dawn phenomena or Somogy phenomena. This means highs over the night during sleep, or low blood sugar during the night during sleep, and both of them will lead to fasting hyperglycemia. Before driving, to confirm hypoglycemia, or during illness. So if you are using self-monitoring of blood glucose by checking blood glucose, you need to, for tight control, to measure in average 6 to 8 times per day. This is very much reading. And if you go for this reading, even if you checked like 6 or 8 times, and you have these beautiful readings like hundreds, this is a real case. I removed the curves in between, and this is a real case. They are checking, and these are the reading. And if you go for the continuous monitoring for the same case, for the same case. You can find that in between these two normal reading spike, which is very high, and here as well. So, and you might find low as well. So in this child as well, this is the reading. If you can read it, it's almost in target, but in between, you can find here overnight during sleep, there is hypoglycemia not detectable because he was sleeping and no one checked his blood sugar. And there was hypoglycemia or hyperglycemia in between these readings. So it's very important that the adding value of given by the continuous glucose monitoring to address hyperglycemia or hypoglycemia or fluctuations. So they found limitation in the hemoglobin A1C, that the hemoglobin A1C has limitations that with a lot of excursions, we have hemoglobin A1C of 7, and with steadiness, still I have the same hemoglobin A1C of 7. Because this actually average between highs and lows, so the average will be the same hemoglobin A1C, while steadiness is. They correlated actually the fluctuation with the complication. That's why hemoglobin A1C alone has limitation. And the fear from hypoglycemia, you need a sensor to address the hypoglycemia and hyperglycemia to reduce the expected harm. So the sensors, actually, it senses not the blood sugar, it senses the subcutaneous fluid, interstitial fluid. It's not the blood. So the traditional blood check, these by the self-monitoring of blood glucose, but with the sensors or subcutaneous interstitial fluid. It sends through electrode, and it takes data every 5 minutes, or even now with the new sensors, every 1 minute you have data. It might need calibration. You calibrate the sensor by 2 to 3 times blood glucose readings, make this input to the sensor to make the calibration. Or better, actually, with the new sensors now, they are factory calibrated. So you don't need to make calibration. It's calibrated in the factory, and the sensor will not ask for any glucose calibration. So it's very convenient to the patients to have a factory calibrated sensor. Of course, there is a lag time expected between the interstitial fluid and the blood, and there is very well understood and expected, and the accuracy of the sensor will be measured against a percentage of accurate reading against the blood reading, and the acceptance or the validation of the sensor will be based on that. And as we said, it's now integrated with the pumps. So it's very important for the factory calibration to overcome any technical issues or false data entry by the patient that will lead to affecting the accuracy of the sensor. There is one indicator used to evaluate the accuracy of the sensor. This, they called it MARD, mean absolute relative difference. And this MARD means how much difference of the sensor against the blood glucose measurements. So what's accepted for the difference to be less than 10% of the data. And most of the current sensor in the market, all of them marked less than 10%. So nowadays, most of the sensors are used, and even 3 years ago, the FDA validated the use of the data from some sensors without double check. So no need to double check for the data before taking action against hypoglycemia or hyperglycemia. The types of sensors or the ways of the continuous glucose management, we have what we call the blinded sensors or retrospective data, and these are professional sensors used to diagnose some diseases or some phases of before diabetes or other hypoglycemia, not in diabetic persons. But these are professional use. Actually, no need to be used in diagnosed diabetes patient nowadays, and you go for the real-time continuous glucose management or the monitoring or the intermittent scan, as I'm going to mention. So for the blinded, as we said, it's indicated for pre-diabetes in type 1 or some forms of very mild hyperglycemia in the morning for the monogenic diabetes like the glucokinase MUND2, and or some cases with cystic fibrosis related diabetes, and to monitor or to diagnose the need for start of treatment or not. And some others like the obesity or steroid use, you might use this because it's only once a single use to take decisions for the diagnosis. We have many retrospective blind forms in many countries. For the intermittent scan means what? It's not real time data. You need to make 1 second scan. You just swap this device against this small sensor, and you will have the data instantly on the screen. And nowadays it's used by the mobile even. So the data will, after making this 1 second scan, you will have the retrospective data for 8 hours. And you can take this data, it's validated by the FDA to take action on it immediately. And now it's with the new versions, it includes some alarms as well. For the real-time data, you take you don't need to make a scan, and you have the data instantly to the receiver or mobile. And for this intermittent, it lasts for 2 weeks, and no need to make calibration. For the real-time, according to the brand you are using, it lasts from 7 days to 10 days, and the recent some companies doesn't need any calibration and lasts for 10 days. For the sensor augmented pump, as I mentioned, so the sensor can suspend the pump on low or before low, or now it's fully automated, and the sensor data will give instructions, orders to the pump to change the doses of the basal or give mini corrections for the bolus as well. Some of the continuous glucose monitoring is implanted subcutaneously with a sensor over it, and this implant will last for 3 to 6 months, and the data even up to 6 months, and it's validated FDA approved. But actually, we didn't have experience with such implants. We don't use here, and there is age limitation as well for these implants. What is the use or the need for this technology? Actually, every one of us needs some commitment or motivation if under surveillance. So the way of the sensor sending data to caregiver, you can share the data from the primary person, who's the diabetic child or the mobile use. You can share data with 5 to 20 persons, including the caregiver. Even the child at the school, still the mother or father can monitor the readings. He can call if he's going down to hypoglycemia and no one is attentive. He can call to give correction if the child has arrows or the readings has arrows up and need to correct it. And of course, all of these data uploaded, most of them uploaded to the cloud or downloaded from home, and you can monitor it while the child at home. And this was very helpful during the COVID time, and now we are running virtual clinics again, but you can have full data and full advice about the dosing without attending to the clinic. So it's the value added by the sensor: more checking and looks for trends and arrows, more adherence to carb entry and coverage, response to arrows and alarms. Arrows means that the sensor will give arrow to show the child and the healthcare provider the trends of the blood sugar. So it gives the arrow up means the current blood sugar is like 120, but the arrow up means it's rising with a rate 1 to 3 grams per minute, or it can show arrows down according to the arrow and the device brand. You can interpret this arrow that it's going down with a rate of 1 to 3 grams per minute, and you can take action to prevent going up or to prevent going down. Of course, as we said, sensor augmented pump and the automated pump, it's very important integration between the pump and sensor. More family engagement, so the family can have the data on their mobiles and they can engage more in the supervision and the management of diabetes. Healthcare provider more data to analyze, and you have graphs rather than discrete reading, as I showed you that the difference between the periods in between normal data might be high or low, and of course the remote monitoring during the COVID time. To validate the data, you need to have continuous glucose monitoring data. They compared 1 day against or 3 days or 7 days or 14 days against data over 3 months, and they found very so against data of 30 days, sorry, and they found that 14 days is very enough and matching with the data of 30 days, so no need to interpret more than 14 days. If you have enough data more than 14 days, it will be very nice. This what they call ambulatory glucose profile. Ambulatory glucose profile, and the way they present the data in graph in most of the sensors now. The download, the looking of the page might change from one device to another, but most of them will have the same graphs. So this one example that you can collect the data from 2 weeks, like discrete data. This each dot means one sensor reading, and I said the readings every 5 minutes or every 1 minute in the recent sensors. So you compress this data and you draw a line to have 50% of the data above and 50% of the data below, and then you draw another 2 lines to have 25% of the data above and 25% of the data below, and then a third line with 10% above and 10% below, and you compress this to have this ambulatory glucose profile with the median data most, and 50% of the data lies in this between these 2 lines, and 80% of the data lies between these 2 lines, and your aim to have a median in the target in between these 2 lines, between 70 and 180, and compressed graph, not wide variability, to have less variability of blood sugar. So this is your target. And they interpret, they collected this target in what we call glucose monitoring data targets. And these targets is very specific, measurable, achievable, realistic, and it should be achieved within a certain time. So you have a deal with your patient to reach this target after some changes in the dose, or changing the technology you are using, or making some decisions about the insulin dosing. So this actually standard CGM metrics, number one, this report, the way of reporting will show this way. Number one will show you how many days you are analyzing. If you have 4 weeks, I like to interpret 4 weeks if I have good data for 4 weeks. But if you have data for 2 weeks, it's still validated. Percentage of the time sensor is active. This means if someone is wearing the sensor for less than 50% of the time, so the data will not be as valuable as someone is wearing 90% plus of the time. So it's very second. Third is the average glucose and the glucose management indicator. The glucose management indicator previously called the estimated hemoglobin A1C. Now we are not saying estimated hemoglobin A1C, we are saying a GMI, or glucose management indicator. Why? Because I'm interpreting data of 14 days or 28 days, while the hemoglobin A1C is a real particle in the body, and it reflects data of 3 months. So this term is more accurate, describing the percentage or estimation of glucose management indicator. Glucose variability will be addressed against a metric called coefficient of variance. Actually, there is a 36% expected variability of the blood glucose, or sorry, interstitial fluid glucose, and this will be accepted as variability. If you have more variability of blood glucose, of glucose more than 36%, 40%, or 50%, this will mean that lots of highs and lows, and this variability is not acceptable. And this one of the targets to have more steadiness of the glucose rather than variable ups and downs. And then you will go for the what we call time in range, time above range, and time below range. The agreement was to have time in range between 70 and 180 to be 70% plus, and time below range between 55 and 70 or below 55 not to exceed 4%, and time above range should not exceed 25%, and it's 2 bars between 180 to 150 and above 250. So you need to have all these reports calculated from the CGM, and here are the target. The target I mentioned, this is specific for pediatric and most of the adults. For type 1 and type 2, still some exception groups. If elderly people or pregnancy, you might be less tight with the elder people and more tight with the pregnancy. So these metrics and targets are changeable accordingly. This is the way of the you have the data in the download, one of the devices we are using. So you will have the metrics of continuous glucose monitoring, like I mentioned. So you have here a percentage of time in range, time below range, and time above range, and the duration and the percentage as I mentioned. So this is one example of one of our patients. You might go for one metric and you are happy that you have 82% target time in range, and you aim only for 70%. So you can look at here and say, it's okay, you are doing great, very good, time in range is very good, keep the same and go home. No, you should have all the metrics in range. And it's very important to address that she has 10% of the hypoglycemia, which is not acceptable. Hypoglycemia should not exceed 5% total, 4 to 5%, and you need to address the reasons for this hypoglycemia and decrease this reason and go from hypoglycemia to increase the target time in range. So it's very important to have all the metrics in line. Of course, you might not have any hyperglycemia and shift all the hyperglycemia percentage to time in range, but you should not accept any increase in the hypoglycemia. As well, this it's easy illustration. Just have a look and you understand this child is out of control and he has a lot of hyperglycemia. By just taking a look at this bar chart, the percentage of hyperglycemia is very, very high, more than 75%. Again, it's very small percentage of time in range and almost 0% of hypoglycemia. So it's very important to move from the concept of the hemoglobin A1C, because it has limitations. As we said, it does not address the fluctuations and variabilities of glucose. And with the wider use of continuous glucose monitoring, you can bridge to the concept of time in range. By the way, the continuous glucose monitoring, if cannot be afforded to be used continuously, still you can offer to the patient to use this intermittently. So if you use one sensor for 10 or 14 days, every month or every 2 months or even every 3 months will be of great value to make proper decisions. We aim at the end to have a complete closing the loop between the sensor and the pump, what we call the complete artificial pancreas. We are now hybrid closing the loop, but still input from the patient to put the carbs and give some data to the pump, and to have a full closing the loop still I prepared some questions to be as a pre-test, but there was no time to have it, so I will just run briefly over the question. I will leave just 10 seconds for you to try to answer. There is no voting system to answer, but just to recall some information I delivered. So with the continuous glucose monitoring, what is the correct target for time in range, time above range, time below range? So you have these options. You can have a look and make a decision, and then I will give the answer.
So participants are able to type their answer in the chat.
Sorry?
Participants are able to type their answer in the chat. So
No. I have the answer already, but we can type in the chat. Okay.
So we have some participants saying 2, some saying 3. The majority of our participants are saying number 3. And
3.
2 or 3.
Okay. So with maybe the guidelines will change with time, but the current guidelines is more reasonable guidelines. 3 is very tight guidelines to have time in range more than 90%. This is a very good objective or target, but we need to be smart, as we said, like specific, measurable, achievable. So achievable to have time in range, as is the guidelines, 70%, and above range less than 25%, 5%, and below range less than 5%. And here is the chart I showed. Okay, using insulin pump, what is the type of insulin used? Long-acting insulin for basal dose, short-acting insulin for bolus dose, or long-acting and short-acting used at the same time in the pump, or you are using short-acting for both basal and bolus doses?
So most of our participants are saying that number 4 is correct.
It is correct. Okay. So bolus insulin dose in adolescents needs to be given after the meal, immediately before the meal, 30 minutes before the meal, or during the meal.
Okay, so most people are coming back saying number 3 is correct. Somebody thinks it's number 2.
Great.
Okay.
Immediately before the meal, not for the adolescents, actually for the young children, infants, but for adolescent, he can tailor his food properly, and he can eat his meal on time. So better to have it 30 minutes before meal. Using insulin pump integrated with sensor, what we call the hybrid closed loop, will still need carb entries by the patient. Will automate the insulin delivery dose for bolus and basal. Will need calibration of the sensor by blood test in some models, because some models are using the factory calibrated and some models are still using the patient calibrated, or all the above.
Okay, we've got people saying 4, that all of the above are correct.
Yes,
so
correct. Thank you.
All of the above.
Yes, still we need to make the carb entries. They automate the basal, and the recent models are basal and bolus, and the calibration of some sensors and no calibration. Yes, and this for some false and true. I will answer. Hemoglobin A1C is superior to CGM as reflex control 3 months accurately. Do you think this is false or true?
False.
False, yes, because it's the continuous glucose monitoring give more data. Accuracy of continuous glucose monitoring sensor limiting its use for decision making and used for overall view rather than single reading dose decision.
So again, our participants are saying that's false.
False, yes. FDA approved to use the data for decision making. Integrated insulin pump with sensor via HCl hybrid closed loop achieved better control with less hypoglycemia or hyperglycemia. This is very straightforward to be true, of course. Okay, number 4, in all glucose sensors, the patient need to do calibration with blood test to validate the readings.
So we're getting mixed answers. Some participants think it's false, some think it's true.
Actually, it's false because not all. As we said, many of the recent devices using factory calibration and no need for calibration by the patient, and this actually preferred by the patient and more convenient. So this false because not all needs calibration. So at this, I will stop and I will be happy to answer more questions. Thank you.
Thank you very much, Dr. Ahmed. Very comprehensive review of significant changes to the updates with regarding monitoring and managing insulin levels. There are a few questions. I'm just going to put one to you for now. We've had somebody ask that there have been patient reports of bubbles in the pump. So what causes these and how can these be managed?
Actually, it's not a big problem to have lots of bubbles of the pump. It just tap on the reservoir and this bubble will disappear. There is what we call fix prime and priming of the pump. So when you do prime, you push the insulin through the tube, and you can just tap on the reservoir, and you can push the insulin till you get rid of this bubble. But some people are very obsessive to push very much units, maybe 30 units or 40 units. They are chasing a very minute bubble. This is subcutaneous. It's not intravenous, and there's very small, tiny bubbles will be of no harm.
Thank you very much, Dr. Ahmed. That's all we have time for this evening. So a big thank you to Dr. Ahmed and Mr. Philip for very informative and interactive and enjoyable presentation. So thank you very much for giving up your time and spending the efforts to put up this evening.
Pleasure. Thank you.
Before we go away, I'd just like to draw your attention to those who are wishing to claim CPD points for today's session. So the link for the session is now open. So you'll be able to go to the website and complete the CPD evaluation, and you'll receive a certificate within 7 days of completing the that survey. So if I could just take a screenshot, a photo of our speakers before we leave today. Mr. Phil, are you able to open your camera? Just adjusting the mask. Okay, great. Okay, so 1, 2, 3. Excellent. Okay, I've got a couple of screenshots there. So thank you again for everybody joining us.
Thank you.
And I look forward to welcoming you back very soon. Thank you very much. Good night.
Thank you. Have a good night. Assalamu alaikum.
Thanks, all.